Hi, guys. I am really thankful for your time today because I need some physical therapy expertise about a complicated patient that I'm having in my clinical setting right now. I'll give you a little bit of background about this individual. Um, Veronica is a very intelligent, driven, hardworking kid. She is well nourished, but she is a wrestler. So there's no contributing factors about her healing process with um, any eating disorder type things. Even when she was able to wrestle, which she is currently not right now, um, she maintained about 17 to 20% body fat. She was not at risk in any sense of the word. This is her second year wrestling, which for women in the state of Indiana is, she's got not really late to the game, but she's got her senior year to compete if we can get her back. During the first match of the year, which was the first weekend in November, November 4th, she had put her arm down as she was being taken out of bounds and did not land on the mat, and the opponent's body weight landed directly on her, so she had her body weight on a fixed flexed arm occur. Her arm buckled. She fractured her radial head, and the physician evaluation at the time, they ignored the medial elbow component because they had to address the radial head to save it from necrosis. It had a very unusual fracture in that it's almost a 4A in that it is articular in nature, but it wasn't commuted. Just it was a little unexpected how that happened. So she does right now, although she's not functioning as a wrestler right now, they're out of season. She does work at what I'm going to call a general country store, and she is able to do those work tasks, but she is unable to throw shot put, which she has done for the last 5 years of her athletic career. But she is running with the track team right now, so she's still participating, but not her arm does not have full motion, and she has a lot of discomfort with it right now. During that initial injury, the medical staff on site treated her as if she had an elbow dislocation, was sent to, because of the deformity, she was sent to the emergency room and they started their care. Her surgery was about 10 days after that, so mid-November. They did acknowledge that she was at high risk for avascular necrosis at that time. And had that open reduction internal fixation. Oddly, for her case specifically, she had a specialized gutter splint that was about 45 degrees in nature. It seemed a little unusual, which was fine. I'm not going to question what the physician had required to make sure the bone was going to heal in the proper position. So she was in that for 3 weeks, and then she was in a stock brace with no motion for another 3 weeks, which kind of put us behind the eight ball on motion. She was finally able to really aggressively start working her motion between Christmas and New Year's of this past year, and she was limited to that 20 degrees of freedom until she saw her physician again, I believe January 10th. So we had about 2 weeks where she was limited, and then we could really start working that extension. Her flexion was initially the problem, and they believe that was probably from scarring, which they wanted to have a nice callus forming, but we were able to get the flexion back. But during that moment, we lost a lot of the extension she had. It's almost like it really shifted from one position to another. Our general course of action right now, she's usually coming in twice a week because we're in that zone of waiting to see the physician now, today, in 4 days. She'll see him on Tuesday morning. But when she does come in to do exercise and motion, um, to try to maintain what extension she does have, we've been using just moist heat to loosen it up before we started anything, and then that gives her a chance to kind of get her mindset into what she needs to accomplish, because at this point she really is adverse to putting herself through the process of forced extension, because not only is she having pain in her bicep region, but also that medial architecture of her elbow hurts. So we've tried to be a little cautious with her. She had been seeing a physical therapist 3 times a week up until 3 weeks ago, because we're now in our second week of spring break. And she was released, I'm assuming, because they were no longer able to show improvement. And then that's when the surgical intervention was probably going to have to be triggered. They had talked about that in early February, that might be a problem, and that's where we're at. The exercises that she'd been completing, we're using the hammer with pronation, supination, her cardinal planes at her wrist. We added some hand and finger strengthening for some of her track activities. She wants to be able to run in relays, and she can't turn and grasp the baton, and that's something we've identified we wanted to help her with. And then also we did a little bit of upper back strengthening to try to put her in a better position. She's very forward rolled, as most teenagers are at this point, but more so, I think, because of trying to protect the motion. She seems like she's trying to get more extension from her torso than manipulating her hand by straightening her elbow. We have used instrument assisted soft tissue mobilization, initially down towards the elbow. Then that was less of a problem. I was encouraged by the surgeon to avoid any direct manipulation over the radial head at this time. And of course I deferred to that. So we worked more muscularly and other soft tissue up in her upper arm and stayed away from that fracture site. She continues to have palpable trigger points that are very noticeable as we begin the active process, the active assistive strengthening. She'll have a little bit of tension, but as soon as we start to extend her, it's almost that protective mechanism really fires in. We can get full extension with some pretty significant pain. She's more comfortable going to about 5 degrees, but she still has to have help doing it. And as soon as she is done, she's immediately back to a carrying angle of about 20 degrees. She does not comfortably stay extended. We'll just say that. Some other background about her, because of the pain that she continues to have with this elbow. She only used her oxycodone post-surgery for 3 days. She refused to use it. I think she actually had our school resource officer dispose of it. She didn't want to use it. She did speak with the surgeon with some prodding by me in December about some kind of a transition step down, maybe going to a Tylenol 3 when we knew that she was going to be having some aggressive physical therapy. Right now, she's only using over-the-counter Tylenol. She will not take any other medicines. She doesn't even like to take NSAIDs. She had a teammate overdose and die from a fentanyl situation about 16 months ago, and she's like, I'm not taking anything. I'm like, okay, well, I think that's an area that I'm going to need some of your advice as to how to navigate some of that, because I've been involved in that painful situation as well. And I need some advice from you all about how to convince her to maybe do that. Take some medications. She does have the appointment with the surgeon on April 9th. Her ulnar collateral ligament is unstable. I will say that when we test it. Neuroglides for that ulnar nerve, just as a more of a testing, elicit a lot of symptoms, not related to the bicep, but additional pain. The PT that we had been seeing did not have the skill or was unwilling to do dry needling. I'm not trained to do that. We're working on getting approval with our new team physician for that to happen. So I can't do it, but that doesn't mean that somebody else can't. And I would wonder if that would be a helpful therapy for her. And again, I want some of your all's thoughts about that. In speaking with her yesterday and going through some of her patient-reported outcomes, she really is hyper-focused on getting her motion back. And she's very intelligent, and I'm sure she's been looking at what happens when they do that Tommy John's procedure, and she knows if she doesn't get back her extension now, she's not going to get it back easily at all. She wants that so she can throw shot put as a senior. She wants it so she can wrestle because right now she can't. She tried to go into referee's position, and are you guys familiar with wrestling at all? Okay, so on her hands and knees, that's how you start. You can be up where we're hand-to-hand combat on our feet, and then they'll have one person kneeling, another person behind. After one of them's been taken, after the person on the bottom's been taken to the ground, or at the start of a period, they'll do that. She cannot do that because as soon as she is on her hands and knees and goes to shift over, she has exquisite pain and instability. So I feel like she's going to need to have more intervention, internal intervention before we're going to be able to address it. But I do want to try to help with her pain management for the second go round, and then certainly once we have a stable elbow, increase her exercise protocol from what we've been given. I think they were very limited to try to protect her a little bit. The other piece to the puzzle that we did notice with the mental health components, we did a patient health questionnaire 9, and I did a disablement of physically active. And she scored at risk significantly on both of those, and you wouldn't necessarily pick that up from the way she presents herself, but she is in need of some additional assistance. Unpacking that with her yesterday, she's having difficulties in class. Being a strong student and intelligent, she's scoring average in some of her AP classes which she shouldn't be, as she's describing that. So that's something else we need to address. So I think from a patient perspective, I would love to have your expert opinions on preparation before she has the other revision, and anything else that we can safely do in the interim before she has to be immobilized again, and then how to proceed after we can really start working with her. So Erin, you're unmuted. Can you help me?
I'm kind of just going off based on like my knee. I had to stage my second surgery. So I had the first ACL, and then I don't know if I think the tunnels were either too big from the first time or something happened to where my surgery had to be postponed the second time. So
Okay.
it's essentially like I was getting another surgery after. So all I could do in that moment was um, work on range of motion, strength, kind of get back whatever you could, like prehab wise, before heading into the next surgery.
Mhm.
If she's already lacking extension, I don't think,
Yeah.
like we kind of say the elbow is like kind of the knee in the upper extremity. So if she's already lacking that extension there, she might not get it back for the activities, obviously, you're saying that she wants to get back to.
Right.
And if she doesn't get that back, that might affect not only sports, obviously, which is the
Up, I think we lost you there.
up. So if we can get that extension back and get that range back and strengthen like the muscles around, I think that's first priority, along with obviously mental health. Giving her, I mean, we talk about yellow flag items and seeing where she is, kind of like fear avoidance, belief, like how she feels about movement in general, whether that's after with sports or just general during PT or AT. Um, like what she's looking like there, especially if it's saying she's saying that it's affecting her classes as well. So kind of seeing where she's at with that, and then addressing that, giving her resources as needed, and then supporting her and growing that rapport with her while you're with her every day, hopefully doing some rehab.
Right, right. Caleb, what kind of wisdom can you impart?
I don't have much wisdom, but I'll just speak what's on my mind.
Yeah, please do.
Um, I guess there's kind of two trains of thought. One is a very biomechanical approach, which obviously needs addressed, including, her point she's dealing with, and just really addressing the fracture site. But then apart from that, I think that's one thing that we can address in the clinical thing, but then also like more of a biopsychosocial approach. Like there's a lot of things there that need
Yeah,
unpacking, especially going into the next surgery. I think if we can address the mental aspect of things earlier rather than later, it's probably going to have a big effect on does it. So I don't know if you guys have talked about referrals at all, but especially not knowing just at face value that she might have stuff to deal with there. Yeah, it's funny. Like a lot of times you don't know what people are dealing with, and then with an outcome like it's something different than you would have expected. So um, having known her measured scores, what types of referrals can we give to this patient to maybe see someone who's better than our kind of the more mental aspect.
that brought me to one thing that in looking at both her disablement of the physically active and the actually honestly the pain inventory we did, she has more anxiety than I would have expected. Um, and she's not sleeping well. She's sleeping on average about 4.5 hours a night. And one of the things that after discovering that yesterday, we discussed, and I'm gonna push that when I see her next week, is using the Calm app, of which I can get her a subscription to that through one of my sources. So cost isn't an issue, but at least having her use that at night, and hopefully be able to get her to use some of the meditation so she can set herself before she tries to go to bed, and then use the 456 megahertz just so she can stay asleep. Because she's not describing it as pain, like she's not being awakened by the pain, but she's awake and then she is aware. It's not like she's when she wakes up, but then I think probably she tries to stretch a little bit and it's sore, but it's not the pain that's wakening her in her mind. Um, she just can't uh, stop processing, I think is the way she described it best to me. So besides the Calm app, do you have any other suggestions for meditation or anything integrative that we could add in?
I mean, you kind of cut out there just a little bit, so I'm not
Okay,
sure
that's
that
okay.
I had everything that you
Mhm.
said, but we talk about 4-7-8 breathing sometimes to kind of slow down. I don't know if you guys have touched on that, but
No, I have not.
so you inhale for 4 seconds and then you'll hold for 7. Tell me if I'm wrong, Caleb, I think. Hold for 7 and then you exhale for an 8 count. I think you don't do that more than like 5 times, but it really just helps to slow down and control your breathing and make sure you're breathing in and out at a steady pace. And it's not like diaphragmatic or anything, but we can do that with our patients that might present with kind of how she is. So
I wonder if that would be helpful as we're doing some of the extension that is a little more painful. Have her focus on that, and maybe we can break the cycle. That's a good idea. Caleb, anything that you can add to trying to calm her down for sleep?
Just piggybacking off of what Aaron said, I think using those breathing exercises to kind of turn off the next system and just figuring out ways to get into a parasympathetic state more frequently throughout the day, I think is really important. We live in a world of go, 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 and especially sounding like very motivated to get back. She's getting her range of motion back. She's probably got all these thoughts swirling around her head all day. Am I going to be able to wrestle again? Am I be able to do this, that? So I think just finding either a professional that can help just get into a parasympathetic state, and just maintaining that parasympathetic um, throughout the day would be really important for her.
You know, you just brought up a good point that I have not addressed with her, but her having brought up, Elijah's
Which I also think
death.
because it's a low hanging fruit to address. So 4 to 5 hours isn't a lot of sleep.
Yeah, she needs to sleep, and I wonder if, and again, I've not asked her if she had formal counseling working through, after his death. So that might be my segue into, because if she already has a relationship with a provider, maybe we can have them revisit that. Thank you for bringing that up. How do I convince her to at least take something to mute the pain, because I can't dry needle her or use acupuncture in the facility because I don't have the standing orders to do anything like that, nor do I have the expertise. But I've got to figure out something besides a hot pack and trigger point therapy to try to break that pain spasm
And I
cycle.
don't know my computer now.
Okay. So what I was saying was how do I work around the fact that she is not going to put anything in her body that's going to mute any pain. She's not going to use an NSAID. She's not going to use Tylenol even now at this point. She'll take it if she has a headache, but that's about it. Okay, hang with me, guys. Yeah. Okay. All right, so we'll go to chat unless Aaron can hear me now. Oh, now I think I've got
I
eyes
can hear
moving again. Eyes moving again. So how do we get to a point where I can affect her pain from a more physiological standpoint, because she is not going to take any meds. And I can't use acupuncture. I can use acupressure or trigger point therapy, and we've had some success with that, but you know, what do you guys think?
You mentioned dry needling. I understand you personally can't do it, but you said one of your colleagues might be able to. And I know a lot of research in that and your therapy. That could be an effective method to at least points that you're dealing with. They're pretty palpable and pretty prevalent. So that could be one option. And I don't know what kinds of manual hands-on have you done? Have you done general mobilizations on the radio? All that has been done. Yeah.
Yeah, it's really is almost a reflexive protective mechanism that muscle just immediately fires. So it's something, and we've even worked up in her neck and shoulder to try to calm that down. And it just immediately comes back as soon as we get her straight, and literally as soon as the pressure's off, bam, it's right. It will not. Her tricep won't fire, or the bicep brachialis just overpowers it completely.
I'd be curious about doing some of that deep breathing, maybe alongside of a treatment, and just seeing. I know it's might not have a correlation, but trying to throw anything at it at this point.
No, I think that might be a good way to stop her, even if it's subconsciousness. If she's focused on that or in the process, that might help.
Mm-hmm.
Okay. Is there any other comments you guys can think in our last couple minutes here together?
She refuses to take any sort of medication.
She is very adverse. She will not. And again, she mentioned, Elijah's situation, and she's like, I'm not even going down that path. So, when part of the inventory that we had to do was talking about substance use and alcohol, and she's not going to disclose if she's taking any alcohol, because that would, to me, because that would be an automatic 40% penalty. She wouldn't be allowed to participate. So I'm not going to get an honest answer out of that. But I honestly don't think she's taking anything.
Yeah.
So I don't, I'm kind of stuck here.
I guess one other strategy that we've had a lot of discussion about in our physical therapy curriculum so far has been revolving around pain education.
Okay.
In athletic training, but the research seems to be pretty convincing that a bit of understanding how pain works and its complexity, and understanding that there's an emotional component to it. It's not just physical, and kind of understanding the basics of that and having it, especially going forward with her ulnar nerve evaluation coming up. I just wonder, to prevent further of the issue, could pain education, that sound like
That's a good idea. I had not thought of that. That's a great idea.
I don't think I have much else to add other than just let her know that pain comes from the brain and it's not, physically where she thinks it might be. Give her the research if that's what maybe she needs, so that it's not just kind of coming from you, it's coming from these things that have been proven. And as for the dry needling, based on kind of what you told us, she might be apprehensive to like seeing what that looks like. So maybe like prefacing that too with some research. And like, I don't know if that like prefacing that so it's not just jumping into, these big needles where you're already having pain, that can be scary. I've had it done and I was apprehensive, so it makes sense.
She actually had asked about acupuncture before, so I think that there's some progress we can positively make there. But I love the idea of educating, because she is a super smart kid, and being able to put those resources in her hands would really help. So hopefully we'll know more on Tuesday, as to what her pathway is going to become. And she was going to take a quick trip to Florida before she got that news. So she's actually on her way there now.
No, very cool.
Yeah, very cool. Was there anything else that I needed to tell you for your portion of this project or anything?
I don't think so. I think you provided a pretty good summary of the patient. I got the main idea of it. Yeah, it sounds like a complex patient to
Yeah, it's not straightforward. Okay, well, we're froze up again. Okay. Oh, there you moved again. Okay, good. All right, guys. I really appreciate your time. Thank you. And I love some of these ideas, especially the pain education. I have not gone through that formally with her. We've certainly had conversations during our sessions about why things happen the way they do, but I maybe sitting down and actually explaining that to her will overcome some of it. I don't know what else we need to talk about. So if you'll hang on a second, thank you for your time. I do appreciate it. And we'll end this part of things.